Hello, everyone. Sorry about the delay. We've had a bit of technical difficulties. Today's presentation is addressing inflammatory concerns and looking at simple protocols that you can use to deal with patients' needs. So, what is inflammation? Inflammation is actually an important process. It's important for injury and the repair of tissue, but we have to deal with, of course, the protection response, the injury, destruction of tissue, which serves to destroy, dilute, wall off both injured agents as well as injured tissue. Inflammation is now recognized, however, as a non-specific immune response. So what happens when we upregulate inflammation? Of course, we live in a world continuously and ever-increasing threats to our health. Inflammation and immune system have work overtime in a manner that they were never intended to, with the stress situations and the state of constant upregulation which we deal with, which eventually leads to dysregulation. Chronic inflammation is a result of genetic predisposition, susceptibility to triggers, overabundance of inflammatory precursors, whether it be through dietary concern with high arachidonic acid, or the type of foods that we consume that has an issue with elevating glycating end products. Insufficient dampening of excessive upregulation by endogenous mediators, lack of nutrients that have an influence on modifying inflammatory markers, or malfunctioning of off switches, inefficient TGF-beta or imbalanced Th1, Th2 lymphocytes. So diet style can be significantly inflammatory. This was in Article 2007 review of cardiology, a Western type diet high in saturated fat.
Wayne, can I interrupt you very quickly? It looks like we've lost our slides.
Slides?
It looks like the video has some of the slides. Go ahead and go back out to the panel, exit desktop sharing, and see if we can't get back into the desktop sharing in the slides.
Okay. Did that do it?
Into it. Can everybody?
Sorry for that. The American diet can contribute to inflammation. Western style diet that's high in saturated fats, simple carbohydrates, salt, low in EPA, DHA from fish, low in phytonutrient content, low in fiber content, has been associated with pro-inflammatory, pro-oxidative, pro-thrombotic tendencies, and consequently in cardiovascular risk. This is something, of course, we all know. There are things that we can do to modify our response to this diet, modify our response to inflammation. This was in the Journal of Biology and Chemistry 2009. Diets high in omega-6 saturated fats contribute to inflammation. Arachidonic acid, of course, is a precursor for pro-inflammatory hormones, prostaglandin hormones, and we'll discuss that as we continue. But increased omega-6 to omega-3 ratio, which we all know the standard American diet is quite skewed to higher amounts of omega-6s, is hypothesized to increase inflammatory mediated production, leading to higher incidences of inflammatory diseases and may impact inflammatory gene expression. Omega-6 fatty acids, in particular arachidonic acid, which is an omega-6 fatty acid, which is quite high and predominant in standard American diet, is a pro-inflammatory fatty acid. It's converted to pro-inflammatory prostaglandins. Omega-3s are less inflammatory or anti-inflammatory. So changing the ratio of omega-6 to omega-3 fatty acids can provide some benefit for reducing inflammation. This was a study in Metabolism 2009. Even body fat is a significant contributor to systemic inflammation. Fat is a pro-inflammatory tissue. This article goes on to state that inflammatory markers are known to increase with age. These results suggest age-related variations in C-reactive protein as well as interleukin-6, two inflammatory molecules, is largely explained by differences in visceral adipose tissue. Adipose tissue is pro-inflammatory. The more adipose tissue you carry, the more or the greater increase in inflammatory molecules from that tissue can arise. Study in clinical biochemistry looking at hepatic insulin resistance, metabolic syndrome, and cardiovascular concerns. Inflammatory diet and lifestyle in turn leads to chronic disease. It goes on to state it's now commonly accepted that chronic inflammation associated with visceral obesity induces insulin resistance in the liver. Chronic inflammation is characterized by the production of abnormal adipokines. These are substances from the adipose tissue that are pro-inflammatory. These pro-inflammatory molecules, cytokines from immune tissue, tumor necrosis factor alpha, free fatty acids, interleukin-1, interleukin-6, leptin, resistin. These are all factors that inhibit insulin signaling. They have an influence on cytokine signaling proteins. There are several kinase enzymes, which are these communication enzymes within the cells. GNK, IKK beta, which is associated with activation of nuclear factor kappa beta that we've discussed with products like Caprex and Caprex AI, incinase, and protein kinase C, and the activation of tyrosine phosphatase enzymes that impair insulin signaling. Inflammation impairs insulin signaling. The activation of these communication molecules that are associated with inflammation can impair insulin signaling and ultimately lead to changes in body composition, and then, of course, ultimately down towards effects on blood lipids and then blood sugar control. Inflammation may be exacerbated by food allergies as well. So many things contribute to the onset of these diseases as we continue through life and have further challenges that influence inflammation. An article in Current Opinions in Gastroenterology looking at food allergies that may trigger systemic inflammation, systemic autoimmune disease and disorders in celiac disease, loss of intestinal barrier function typical of celiac disease, gluten sensitivity could be responsible for the onset of autoimmune diseases. The response can be theoretically stopped and perhaps reversed if the interplay between autoimmune predisposing genes and triggers is prevented or eliminated by a prompt diagnosis and treatment, which of course in this context it would be a gluten-free diet. Barrier function in the intestinal tract is very important to reduce the absorption of toxins or other intact proteins into the system, which of course in turn we respond to as invading proteins, invading compounds, and possibility of setting up an autoimmune reaction is quite prevalent in those cases. Gastroenterology, looking at food allergies which may develop over time and contribute to inflammatory diseases. They go on to state that the data shows the first time that the prevalence of autoimmune disorders and celiac disease is related to the duration of exposure of gluten. So diagnosing the concern, the sensitivity to gluten quicker, and is going to have a much greater impact overall in long-term associated with autoimmune disorders being prevalent in these individuals. And we see a relationship between inflammation and gluten sensitivity. In the Functional Medicine Research Center, we've looked at our management study patients that had autoimmune disorders, and an interesting correlation between gluten sensitivity and autoimmune disease was found. Interestingly enough, we found that 96% of the patients that had autoimmune disorders that presented at the Functional Medicine Research Center with autoimmune disorders were gluten sensitive with elevated immunoglobulin A autoantibodies. 6% of those individuals with autoimmune diseases presented with gluten sensitivity. Off-site medical doctor, Dr. Kenneth Fine, reported that 62% of his patients with autoimmune diseases were gluten sensitive. So there is an incredibly prevalent concern associated with autoimmune disease. Every patient that presents with autoimmune disease should be assessed to look at gluten sensitivity as a predisposing factor for the inflammatory condition. With tolerance, of course, we have celiac disease as a primary concern, but other autoimmune diseases, whether they be dermatological, cognitive, hepatic, cardiac, musculoskeletal, neurological, or endocrine, could have theoretically a concern with gluten intolerance. And again, we're seeing a significant prevalence of individuals with gluten intolerance when they're presenting with these autoimmune inflammatory conditions. In Gastroenterology 2001, again suspecting food allergies in patients with inflammation. For every symptomatic patient with celiac disease, there are 8 patients with celiac disease and no gastrointestinal symptoms. So the prevalence here is very large. Assessing patients with autoimmune inflammatory concerns is going to be a very important component of dealing with their inflammatory issues. The study in experimental biology and medicine looking at the mounting evidence for vitamin D as an environmental factor affecting autoimmune disease prevalence. Of course, we know that vitamin D deficiency is quite prevalent in society. So low vitamin D may also play a role in inflammation. There's an inverse relationship with MS, type 1 diabetes, rheumatoid arthritis, and IBD and vitamin D status. Patients with autoimmune diseases express a genetic polymorphism for vitamin D regulatory genes. So there's the genetic predisposition in those individuals because of these polymorphic concerns associated with vitamin D activity. So on top of the fact that there's vitamin D deficiency, there's also concerns associated with the activity of vitamin D. Vitamin D and chronic inflammation. Epidemiological or geographics on autoimmune disease is that suggesting an environmental risk factor of insufficient sunlight exposure. Individuals with autoimmune disease in northern climates, there's a greater risk of autoimmune diseases in northern climates where there's a decrease in sun exposure, a decrease in vitamin D in those individuals. Vitamin sun exposure is inversely correlated with autoimmune disease prevalence. And one dihydroxy D3 implications in prevention of autoimmune disease, type 1 and 2 diabetes, cardiovascular disease, osteoporosis, cancer risk of hormone-sensitive tissues, as well as MS. You can see preclinical autoantibodies developing well before the onset of disease. Individuals presenting with an elevation in autoantibodies without a specific diagnosis is for many autoimmune diseases. This is from the England Journal of Medicine, 2003, development of autoantibodies before the clinical onset of SLE, but it's true for autoimmune diseases as well. Individuals will present with a history of autoantibodies previous to the diagnosis. Years prior, one can see an increase in autoantibodies prior to any type of symptomatology. This was in the Journal of Lupus in 2006. Inflammatory conditions may be managed through diet and lifestyle well before manifestation of symptoms. Individual presenting with autoantibodies, there's an inflammatory process going on in their system. So they have looked at several non-randomized small-scale studies having suggested that autoimmune disease could be prevented if treated aggressively prior to manifestation of symptoms. And it can be done, of course, with an anti-inflammatory diet and lifestyle. Individuals who are at risk of developing an autoimmune disease should be advised to refrain from activities and lifestyles which endanger their health, in quality of life. And of course, also includes poor dietary choices. Lifestyle either manage or contribute to inflammation in your patients. Markers that you can assess for inflammation, of course, homocysteine can be assessed, hemoglobin A1C as a marker of blood sugar control, sensitivity C-reactive protein, and again, as we've been seeing with autoimmune disorders, sensitivity, antibodies. You can also get patient history as well as doing health assessment questionnaire like the health appraisal questionnaire. There are some assessment tools that can be used for arthritis assessment models, the WOMAC from joint between Western Ontario and McMaster University assessment tool, as well as the arthritis impact measurement scale. These are all available as assessment tools that can be used to look at evidence of inflammation in patients. What chronic inflammation? Of course, there's a genetic susceptibility to triggers, but what can control is, of course, diet, and poor diet increases presence of inflammatory compounds, and we'll discuss how that is. You see regulation of inflammatory signals as well, poor hormones, exposure to toxins and pathogens, dysbiosis in the intestinal tract, or a malfunctioning brake on the immune system. Those control mechanisms that are associated with decreasing inflammation, and this could, of course, be associated with vitamin D deficiency. Vitamin D is a hormone. It acts as a hormone in the system, and it's very important for balancing immune function. It's very important for balancing inflammation and controlling inflammation. This was a clinical experimental immunology. We use a definite connection between the gastrointestinal tract and inflammation. Our immune tissue is associated with the gut. Gut-associated lymphoid tissue represents almost 70% of the entire immune system. 80% of the plasma cells reside in the gut-associated lymphoid tissue. Immune mechanisms implicated in these actions are very complex and belong both to innate and adaptive immunity. Gastrointestinal health is a critical component to deal with inflammation, and it can contribute to the inflammatory cascade. There's an interaction between immune cells and dietary input, and this, of course, also impacts inflammation and can have an influence on systemic response. Lymph nodes in the GI tract allow immune cells to trigger in the GI and ultimately circulate throughout the body. You get migration of antigens across the GI barrier if barrier function is compromised, and this again may trigger a systemic immune response. The considerations is the breakdown in barrier function again may be associated with the onset of autoimmune disease. So in the tissue that lines the GI tract, you have your gut-associated lymphoid tissue, your Peyer's path, mesothelial lymph nodes, antibodies line the GI tract. We have secretory IgA that tries to deal with pathogenic organisms that get through the barrier. Permeability and damage to this intestinal tract, nutrition, dysbiosis, bad bacteria, yeast overgrowth, toxic exposure from these bacteria all contribute to break down the barrier function. Of course, there's communication between our system and what is going on within the gastrointestinal tract. So proper communication between GI and immune tissue is critical for good health. That GI barrier and the influence on those lymphatic tissues are in constant communication. Nutrients, good bacteria, which are in the gastrointestinal tract, will have this positive influence on how our immune cells respond. Dietary signals will influence immune function. Probiotic signaling will influence immune function. But of course, if there's antigens or toxins that get through the barrier, there's going to be a negative response as well. We have an increase in pro-inflammatory molecules being produced, again, to deal with these substances that cross the barrier. Increased production, these pro-inflammatory molecules, response of the B cells to produce antibodies that will deal with the compounds that are getting through the barrier. And if once that occurs, then there is a secondary response with increase in of course, these substances go through circulation into the liver, and you get increased liver stress. You get activation of Kupffer cells that further cause an increase in immune response and inflammation. It can be as simple as low inflammation, where you get compromised substances getting into the system, and then of course the autoimmune response within localized tissue like joint tissue, or be a systemic inflammatory response. Diet can play a significant role as contributing to the pro-inflammatory process. High levels of dietary arachidonic acid, which of course, I guess, our source of arachidonic acid comes from animal protein, and it can contribute to increased production of pro-inflammatory hormone molecules called prostaglandins. You have increased inflammation, which causes an increase in expression of certain enzymes. In this case, we're looking at the cyclooxygenase 2 enzyme. Its substrate arachidonic acid, which is, if it's rich diet, there's a significant amount of it that's available for conversion into these inflammatory signals. And this arachidonic acid we see goes through convert the COX-2 enzyme into series 2 prostaglandins, and prostaglandin E2 is a very significant pro-inflammatory molecule. What we want to do with it is, of course, manage inflammation with what we refer to as a three-step protocol. Change the primary dietary signals with first-line therapy program and medical foods that we have that are anti-inflammatory. We send strong dietary signals to calm inflammation and to support leg tissue within the intestinal tract. We want to modulate cell signaling. We want to change the way that the cells respond to these pro-inflammatory molecules. We do this by certain nutrients that we refer to as selective kinase response modulators. These communication networks that are responding to these inflammatory molecules can be modified. They can be changed. We calm these inflammatory signals that impact response. In this case, we're looking at nuclear factor kappa beta as an activator of nuclear factors that are associated with increased production of these pro-inflammatory substances. And we want to look at key nutritional support. There are specific nutrients, phytochemicals that support balance of inflammatory processes. We'll get into more detail as we continue. Our autoimmune protocols used at the Functional Medicine Research Center, whether it be inflammatory bowel disease or rheumatoid arthritis, is to recommend the first-line therapy gluten-free food program. You can find in our first-line therapy guidebook. It's an anti-inflammatory medical food, 2 serves of this anti-inflammatory medical food per day. A combination of reduced disulfur acids from hops, selenium, vitamin D, and zinc can be our selective kinase response modulators. Of course, a supplementation of essential acids, ones that are high in EPA. A product that contains a significantly higher ratio of EPA in particular, because EPA is our anti-inflammatory omega-3. So primary dietary signals, this was in Pharmacogenomics in 2007. It went on to state that prevention and treatment of chronic disease are influenced by naturally occurring chemicals in food. these substances in processed foods have been processed out. These nutrients are very bioactive, and they may produce different physiological phenotypes among individuals because of genetic variability, and not only alter health, but also disease initiation, progression, and severity. Many nutrients can influence the production of these inflammatory molecules. This New York Academy of Science in 2006 modified the overwhelming dietary signals that contribute to inflammation. It goes on to state that a lot of research is focused on immunomodulatory effects of several nutrients: fatty acids, uric acid, EPA, your omega-3 to omega-6 to omega-3 ratio, antioxidants, the type of carbohydrates that you consume, complex fiber versus simple sugars, specific amino acids, micronutrients, alcohol. They all play a crucial role in maintenance of an optimal immune response. In addition, specific dietary patterns are evolving as protective against cardiovascular disease because of their inflammatory properties. This is why we developed the modified Mediterranean diet and included in the first-line therapy program. We can continue in an anti-inflammatory. We can continue on and make suggestions for an anti-inflammatory modified Mediterranean diet. We can change and make it a gluten-free modified Mediterranean diet, again depending on the needs of the individual. So overwhelming dietary signals, as well as modulating cellular signaling with inflammatory bowel issues, do with products like Inflammex Plus 360. The Ultra Inflammex Plus 360 provides a significant amount of antioxidants and anti-inflammatory nutrients, as well as the hops-derived reduced isoalpha acids. So the medical food helps to calm the activation of those lymphatic tissues associated with the intestinal tract, and of course have a benefit on improving barrier function as well. And there are nutrients that balance the inflammatory process. This product has a significant high ORAC value, which is a value associated with its antioxidant potential. It provides nutrients that are anti-inflammatory and nutrients that support, again, barrier function. And the kinase response modulators to the hops-derived isoalpha acids that reduce inflammatory signaling. It's a team-based product, so there's low allergen potential. Of course, low allergen potential helps to reduce inflammatory response. There's a significant amount of glutamine per serving, which helps to nourish the collates that help to improve barrier function. The phytonutrients send balancing messages to the lymphatic tissue in the intestinal tract. And again, very high antioxidant content of this product. If you're familiar with the ORAC value, a serving of Ultra Inflammex is roughly around 17,000 on the ORAC scale. So of course, can produce reactive oxygen species, which are contributing to the pro-inflammatory state. So the rice protein is also fortified. Rice protein has two limiting amino acids, threonine and lysine. The carbohydrate is also a combination of the complex carbs. The rice syrup solids is the complex carbs from rice, as well as rice bran as a fiber source. There are healthy fats in this formula. There's olive oil, as well as medium chain triglycerides, which are also nutritive for the colonocytes. And it's a complete vitamin mineral combination with additional anti-inflammatory herbs. So the ingredients that are supportive in Ultra Inflammex include the Ultra Inflammex Plus 360 include the reduced alpha acids from hops. Again, these are modulators for that nuclear factor kappa beta that activates promolecule production and response signaling. Promotes healthy eicosanoid metabolism rosemary and turmeric also have modulating effects on nuclear factor kappa beta and other antioxidants that scavenge free radicals. The limb may also reduce mast cell degranulation and affect arachidonic acid release. The oxidants in Ultra Inflamex Plus 360, they help to reduce tissue damage by reducing free radical production, which is, of course, increased in the presence of inflammation. It has a comprehensive profile of vitamins, A, D, E, D, B complex, and zinc, also providing antioxidant support. There's multiple mechanisms with Ultra Inflamex. We can recommend Ultra Inflamex Plus 360 medical for patients presenting with inflammatory bowel issues, ulcerative colitis, Crohn's, as well as systemic inflammatory concerns like rheumatoid arthritis. And again, it's simple, convenient, 2 servings per day. There's both a quick start guide that provides easy understanding of how to use the product, as well as a more comprehensive patient guide. Flavors that improve compliance, so you don't deal with taste fatigue. Ultramex is the better choice when individuals are on Coumadin, because the Ultra Inflamex Plus 360 reduced isoalpha acids may theoretically influence the metabolism of Coumadin. They're not thinning in and of themselves, but the theoretical possibility of it influencing the metabolism through the liver of specifically Coumadin or warfarin. So Ultra Inflamex is the choice. Ultra Inflamex Plus 360 for those patients that are on Coumadin for blood thinning. People experience initial gas and bloating from the not only the fiber in the medical food, but actually consuming a liquid food. So suggestions to reduce the dosing down and slowly increase to the full 2 servings twice daily is important, especially for those that are already experiencing some GI symptoms. Any liquid food product has a faster transit time through the intestinal tract. Individuals with reduced digestion or having maldigestion, malabsorption may experience this gas and bloating when they start with a full serving. It's always important for those individuals that are presenting with GI issues to start slowly. So let's look at the step 2, which is modulating cellular signaling that triggers inflammation. We create selective kinase response modulators as these substances that calm inflammatory signals upstream. And in particular, we can look at the cyclooxygenase 2 enzyme that's produced by these immune cells when there's an upregulation due to inflammation. So kinase are a primary research target for managing inflammation. This particular review was looking at Medicine and Chemistry 2007. They wanted to state that we summarized the use of small molecule protein kinase inhibitors relevant for acute and chronic inflammation based on their essential role in cellular signaling mechanisms in immune cells, such as macrophage, lymphocytes, and granulocytes. These kinase enzymes are a target of drug research, looking at how they can modulate or modify these immune cells specifically so that they can reduce inflammation. Your non-steroidal anti-inflammatory drugs, your cyclooxygenase 2 inhibitors, your selective cyclooxygenase 2 inhibitors, they inhibit directly the enzyme associated with in this case, prostaglandin E2 production. However, you can modify the production of that enzyme from these pro-inflammatory immune cells, and that's the goal of many researchers now into drug therapies as anti-inflammatory therapies, both for acute and chronic inflammation. This is what these substances, the derived disulfide acids, actually do. Influence the production, not the enzyme directly. And go on into that in a a little bit more detail. We're looking at the signaling here. We have a pro-inflammatory molecule on the outside of the cell, the cytokine red arrow. It in turn activates multiple kinase enzymes within the cell. One in particular here, we're looking at phosphatidylinositol 3 kinase, PI3K. That in turn activates IKK, which is another kinase associated with the nuclear factor kappa beta. Blocking that nuclear factor causes it to migrate to the DNA and ultimately increase the production of cyclooxygenase 2. That in turn increases, or activating those genes that produce cyclooxygenase 2 increases the pool of cyclooxygenase that's available, and then work on arachidonic acid, that dietary omega-6 fatty acid, to produce prostaglandin E2, and the inflammatory process begins. We can inhibit the COX enzyme directly. That's what total anti-inflammatory drugs or selective COX-2 inhibitors do. There are natural substances that do that as well. Ginger, turmeric do that as well, albeit in a weaker way than your NSAIDs. But a number of different areas we can look at would be modifying the kinase enzyme activity, reduce the production of the cyclooxygenase enzyme to begin with. Arachidonic acid that's available as well by changing dietary patterns, increasing omega-3 fatty acids and decreasing the sources of arachidonic acid and omega-6 fatty acids can reduce the amount of arachidonic acid available for the enzyme. And as I mentioned, curcumin from turmeric, ginger also can influence the COX-2 enzyme directly. So there are multiple things that we can do in terms of dietary interventions that can reduce the overall inflammatory response. Substances, selective kinase response modulators, because we're many kinase enzymes. As I mentioned, this is associated with communication network throughout the cells. We want to select those specific enzymes that are associated with these specific kinase enzymes that are associated with inflammation or activation of immune cells that in turn produce these pro-inflammatory molecules. And we've identified a number of kinase enzymes as targets for these therapies. In particular, one compound that we've looked at, as I mentioned, is inositol 3 kinase. Considered to be a target goal for the next generation of therapeutic drugs for inflammation. So the insight gained so far into the main challenges that are emerging on the path to developing phosphatidylinositol 3 kinase gamma inhibitors for the treatment of human disease. And the potential for therapies which are going to be influenced if you can modify phosphatidylinositol 3 kinase enzyme activity is absolutely staggering. There are so many tissue-specific effects that I3K influences that it's just incredible what, if one can modify that enzyme, what you do. So 3K is a primary target for the management of inflammation. This was in Nature Medicine 2004. They go on to state that our results identify selective PI3K gamma inhibitors as potential therapeutic molecules for the treatment of chronic inflammatory disorders such as rheumatoid arthritis. And we have the molecules that do that, the alpha acids from hops. So the high compounds, whether they're reduced alpha acids or tetrahydroisoalpha acids, there are many different compounds that are called isoalpha acids that are from hops. They impact phosphatidylinositol 3 kinase dose-dependent manner, and these are doses that can provide therapeutic benefit orally in humans. significant reduction in PI3K activity can be with these hops-derived compounds. And if we compare these hops-derived compounds to other substances on the market, in this case we compared celecoxib, we find again a very significant, if not more beneficial effect because of the safety associated with these compounds when comparing to other substances that are on the market. This was looking at a model of collagen-induced arthritis. Showed the tetrahydroalpha acids were on par with celecoxib in terms of reducing the arthritic index. So we had these selective kinase response modulators in our medical food products. The Ultra Inflamex Plus 360 contains the reduced isoalpha acids. We also have them in combination with other antioxidants as a standalone nutraceutical. Combination of the tetrahydroisoalpha acids, rosemary, and oleanolic acid is one of the products that Metagenics produces as a nutraceutical. So you have to use it either in a medical food or again, as a standalone. Is, of course, looking at key nutritional support, specific nutrients and probiotics that support the balance of inflammatory process, whether we want to improve barrier function or cellular within the lymphatic tube and the gastrointestinal tract, or antioxidants and nutrients that are going to be supportive systemically. One product that Metagenics has, which contains the Lactobacillus plantarum 299V strain, specific to the 299V strain. These characteristics have been shown to be of benefit for internal injury and inflammation. That was a study done in colorectal disease in 2001 on this very specific strain of Lactobacillus plantarum. Essential fatty acid supplementation also can be of benefit. As we've discussed, they can displace the pro-inflammatory arachidonic acid and reduce the cell's inflammatory potential. Vitamin D also very important for immune response. Again, a lot of research showing that increasing vitamin D intake may decrease the incidence and severity of autoimmune diseases. In particular, the L. plantarum 299V strain, there's again been a number of studies showing that Lactobacillus plantarum 299V can improve not only outcome from patients, but also increase the response to other therapies associated with inflammatory bowel issues. This was another study, the colorectal disease in 2001. They reduced intestinal injury and inflammation and improved colonic healing as well. There's responses as well to Lactobacillus plantarum 299V. This was looking at effects on inflammatory markers such as interleukin-6 and fibrinogen. In this study, taking Lactobacillus plantarum 299V had an influence on cardiovascular disease and risk factors in individuals that were smoking. Fibrinogen concentrations fell 21%, and there was a reduction in plasma interleukin-6 as well. So the environment that occurs when supplementing with very specific probiotics, very specific strain-specific probiotics, can be seen systemically as well. In experimental biology and medicine 2004, mounting evidence for vitamin D as an environmental factor affecting autoimmune disease prevalence. They state that this review discusses the increased evidence pointing to a link between vitamin D and autoimmunity. Increased vitamin D intake may increase the incidence of severity of autoimmune disease. In 2009, they state that vitamin D and mortality in older men and women they concluded that levels are associated with all-cause mortality and even more pronounced with cardiovascular mortality. So the correlation between vitamin D deficiencies of vitamin D and disease is becoming more and more apparent. Associated with metabolic syndrome. This was a Nutrition review. They went on to state that recently the importance of vitamin D status as a risk factor in the development of metabolic syndrome has been focused on for in several studies. Again, the relation here being that inflammation is a driving force behind the onset and the continuation of metabolic syndrome towards more dysfunction with blood sugar control. Omega acids also, again, reduce inflammation. This was a study in kidney in 2005. EPA reduced lipoproteinide-induced inflammation response in certain cell tissues. Both EPA and DHA reduce expression of tumor necrosis factor alpha, interleukin-1, and interleukin-6. Both EPA and DHA reduce the expression of nuclear factor kappa beta. So we have substances like the hops diisoalpha acids that influence nuclear factor kappa beta. Interestingly enough, the many dietary substances that signal and respond and influence nuclear factor kappa beta. EPA being two of them. EPA is arachidonic acid in cellular membranes. So if you consume a diet that's high in EPA, you change the cellular membrane of those tissues, and if cyclooxygenase is activated by cytokine production, of course the EPA is the substrate, as is arachidonic acid, and series 3 prostaglandins are less inflammatory, or actually anti-inflammatory. So sort of balance, reducing prostaglandin E2 produced from arachidonic acid, increasing prostaglandin E3 from EPA will have influence on the ultimate response to the inflammatory signaling. This is a good look at it. Population, we have an insignificant amount of essential fatty acids coming from the omega-3 family. This is stating a 22-to-1 ratio. I've seen it even higher than 22-to-1. It gives you an idea of the amount of arachidonic acid relative to PA that we get in a diet. That consume a traditional Japanese diet will have something more of a 1-to-1 ratio of EPA to arachidonic acid. And again, individuals will respond very differently to pro-inflammatory signals. Cyclooxygenase in the American diet consuming individual will produce significant amounts of prostaglandin E2, which is pro-inflammatory. This of a production of prostaglandin E2 in the individual consuming higher amounts of EPA. And if you look at Greenland Eskimos, for example, where their diet is significantly higher in omega-3 fatty acids, one at one is at a significantly higher ratio of EPA to arachidonic acid. And again, the response to pro-inflammatory molecules will be quite different. These patterns are quite different. There's a significant decrease in cardiovascular disease risk in these individuals, even though they're consuming a high-fat diet. But the type that they're consuming is contributing to their overall health. So how do you implement these therapies into your practice? Well, the protocol for excellent patient outcome would be to the Ultra Inflammax plus 360 medical food, again 2 servings per day. The nutraceutical, which is a combination of the tetrahydroisoalpha acids, rosemary, and oleanolic acid. Products that are anti-inflammatory, like the Lactobacillus plantarum 299V. Convenient dosing, 1 per day. Use an EPA-DHA that is going to be high in EPA. A 6-to-1 ratio would be a good suggestion. Ratio is not important It's just basically the amount of EPA that you can get per capsule is the important consideration. And of course, vitamin D, depending on if you've assessed serum levels or not, you can range dosing anywhere between 1,000 and 5,000 IUs. Let's look at case histories that we've seen at the Functional Medicine Research Center in Gig Harbor. The management study looking at a patient with SLE. The patient had a painful swollen joints and muscle pain, skin rash, unexplained fevers, psoriasis, nervous system symptoms, nods, Sjögren's syndrome, photosensitivity, edema, and weight gain, and extreme fatigue. As was unknown, there was a combination of factors considered: genetic, different genes that were involved, environmental, which was sun stress, hormonal factors or lack of sunlight, hormonal factors, infectious agents, or drugs. And immune cells for hyperactivated in SLE, the number of activated B cells produced IG and active T cells increased in peripheral blood. B cell abnormalities are present in family members and may precede SLE development. There's raised interleukin-6 and interleukin-10 concentrations, and it may promote B cell hyperactivity. B cell and T cell response to activating signals are abnormal as well. So this presented in 2002 with flu-like symptoms of fatigue, aches, and pains. There were a number of medications for cholesterol, lisinopril, warfarin. She discontinued while on remission. In 2004, the symptoms returned. She was placed on steroids. Steroids caused mood swings. Several months before presentation, she was diagnosed with SLE and started Plaquenil. Caused more fatigue. She was given prednisone, 2.5 grams per day for more energy. So this was her medication, as well as some of the other things that she was doing: supplementation, multivitamin, flax oil. She was taking tyrosine. Initial assessment was for SLE. So had glomerulonephritis as well as hypercholesterolemia. So her initial plan here was to put her on an anti-inflammatory medical food product. This was the Ultra-Inflamex, and we supplemented with the reduced alpha acids from hops, D, zinc, selenium. And this is a nutraceutical for autoimmune supportive. 6-week visit, there was higher energy levels. Fluoridamide on her own. At 6 weeks, she began EPA DHA, which is a higher concentration, 600 milligrams of EPA, 400 milligrams DHA, and she was doing that 2 of those 3 times daily. She continued with the elimination diet, but was also including an anti-yeast and decrease in protein and natural diuretic diet. She began probiotics, and she began a berberine-containing formula as well, a Metagenics nutraceutical. At night, she said she had more energy. She was no longer taking the Inflammide, and she reported having not felt this well in quite a long time. At that point, she continued on the prescribed program. At 1 week, the patient was feeling very well. Energy level was excellent. She could rely on her energy without a slump in the afternoon. The patient discontinued her Plaquenil and prednisone. The edema and joint pain and discomfort had all resolved. At 2 weeks, patient feeling very well. Energy levels were excellent. She started on a gluten-free diet after looking at stool gliadin antibody lab test. So she continued on a gluten-free diet, of course, for the rest of her life. And continued on the prescribed program with the medical food and the anti-inflammatories. So this is her medical symptoms questionnaire score from beginning to end. She had a significant improvement from a sort of 52 initially down to 0 at 60 weeks. When, as I mentioned previously, we assess the patients have autoimmune inflammatory concerns for gluten sensitivity, and we're seeing quite an astounding number of them dealing with sensitivity to gluten. So even symptoms, we're seeing a positive response to gluten antibodies. We see well in other prone intestinal as well, ulcerative colitis or Crohn's. And of course, all patients are put on a gluten-free diet. So this case, inflammatory immunosyndrome. Initial assessment indicated inflammatory immunosyndrome, joint and soft tissue pain, tissue breakdown, Raynaud's phenomenon, fibromyalgia, hypertension, hypercholesterolemia, and allergies. Here was to put her on the anti-inflammatory medical food, the nutraceutical that combined the hops, reduced alpha acids, selenium, vitamin D, and zinc. She was on essential fatty acids, omega-3 fatty acids, EPA, DHA, vitamin D that contained isoflavones, indole-3 carnol with rose extract, and the gluten-free food plan as well. She had a 9% improvement by week 20 after years of suffering. Significant decrease in high sensitivity CRP, significant decrease in sedimentation rate. Patient estimated a 90% improvement in foot pain, was able to walk in sand with no discomfort. She had been able to discontinue her medications as well. Looking at her MSQ score. So she ended with an MSQ score of 79. The medical symptoms questionnaire, if you're not familiar with it, is a questionnaire that gives you a quick overall picture of symptoms related to gastrointestinal concerns, systemic concerns that can easily be done with patients in your clinic. So she had significant resolution of symptoms based on the MSQ, 92% decrease. So the call for excellent patient outcomes would be to use the Ultra Inflamex Plus 360 medical food. Again, 2 servings per day, simple, easy to incorporate into the dietary recommendations. The isosulfuric acids, rosemary, olenolic acid combination would be 2 soft gels daily. The Bacillus plantarum 29V, 1 capsule per day, and a high-dose EPA DHA or a high EPA formula. And vitamin D3 ranges depending on the severity of deficiency if you're assessing serum levels. So please bring this approach in your practice today. We've gotten some very, very amazing feedback from patients at the FMRC, and this is a great core protocol to deal with when patients with inflammation.